Hey, I'm Mason with Live Oak Testosterone. I'm here with Dr. Grant, who's going to ask some questions about everything. If you give us a quick backstory about who are you, how did you get into hormones, and we'll go from there.
Yeah, so my name is Jordan Grant, and I board certified, or was until we quit our jobs last year, but trained urologist. Went to med school at Texas Tech and residency down in Central Texas at Baylor Scott and White there. And my wife is also a urologist, and we practiced for about 7 years outside of residency. And I got into hormones, though, long before I ever even went to medical school. I got into the bro side of it back in high school, looking into the PED use and all that. But I became fascinated with how powerful hormones were, and tried to really learn about them. And I mean, I was researching these things as best you could in like 1997, online. There wasn't a lot, but actually there's more than there is now, as far as ease of finding things. Anyway, but yeah, I got interested in that. And so I knew during med school and in residency, I knew I always wanted to do something with it. So I just made it more of a focus during my urology practice. And once we knew we had to kind of get out of that for multiple reasons, it just made sense to keep doing this, since that's what I've always been passionate about for so long. So now we're doing it on our own.
Yeah, that's awesome. And so you've kind of switched from the traditional medical model, kind of the sick care model, to more kind of concierge based, but hormone focused. Has that been better for you overall from, a provider standpoint, a lifestyle standpoint?
100%. And if you ever get involved in the whole is it direct primary care movement, and you start reading the blogs and forums, and you see the stories are all the same for like me, like the stresses that were just piling up in the regular allopathic system became, I mean, we were having physical symptoms from it. I mean, it was just getting to the point where I knew we couldn't sustain it. And then just the negativity just feeds on you. So yeah, it's been amazing. And I can't imagine going and doing the insurance part of things. I mean, we don't, it's me and my wife. We don't have staff and all that. We're trying to run as lean as possible. And just to be able to process insurance, like the time it would take would require employees. And we don't want to mess with that. And I don't know, getting hamstrung by the insurance companies is never something I was fond of. My wife and I really loathed that part of the job, where you'd order something and it would be denied. And then you talk to them on the phone, they're like, okay, sure. And it's like, why was my order not good enough for you? Yeah, we
Exactly.
all
Yeah.
get that. And, but it's just constant denials for no good reasons and other things. But yeah, I think the concierge model outside of even hormones, like I think it's a great model. In fact, I spoke with some of my prior people that I knew in residency a few weeks ago at a funeral, and some of my attendings there, and they're even starting to understand the problems with the regular model. And they're even mentioning like cash pay urology. Like, and these are people I never would have imagined would be talking about that. It was good. I mean, it was like, yes, I've been talking about this for a long time. Like, these places. Anyway, we could rabbit trail about that, but on a different day. But yeah, it's I think the concierge type model it's great on both ends, and the lower stress levels us to stay sane, because we just wanted to just walk away altogether.
Yeah, for sure. And so, like, I mean, urology as a specialty is amazing. I mean, the surgeries, your hands-on, everything. Did you, and I mean, urologists handle a lot of TRT management for guys. Did you get a lot of training on it? I mean, I have a few friends that, are primary care docs, and they just were like, we maybe brushed over it at 20, 30-minute lecture, if that.
Yep. Yep, that's about it. It's what you get in med school, which is really nothing. It's the standard, you learn the pathways and all that. But as far as like how to treat, it's the standard, whatever's in the endocrinology guidelines at the time, that's what you get. And in urology, there wasn't just not a huge focus in our didactics part of our training. We were very surgery heavy, clinical experience heavy. And yeah, we still had to do our didactics, but it was more focused to just, you get your boards, and that's the whole point. You learn on the job, and that's what I loved about it. But anyway, I don't know where I was going with that. But remind me what you asked me, because like I said, I rabbit trail.
Yeah, no problem. Just like from urology standpoint, a lot of the guys or locally, most of the patients, if they're interested in
Oh,
TRT,
training on it.
one, yeah, the primary docs here, if they get anything, they may get a total testosterone, and then if they have any questions, send them to urology. And so urologists are kind of portrayed as the specialist in
They
TRT, but
should be. I mean, yeah, it got so frustrating. That's where I knew we were going, because I was rabbit trailing into
yeah.
I was so I got frustrated about it even in residency because I did want to start. I started treating people in my own clinic. You know, they give us a clinic, and even then, it's like, what's Grant doing? He's all obsessed with TRT. Like, it's just a joke, you know. And it's gotten more popular now, obviously, because it's had to. But when we were, it was still looked at from the mainstream medical field as just people who wanted to be on hormones were kind of crazy. They just wanted to get big, like steroid users. Like, there was all these urban legends, all these biases against. Especially men who wanted to take testosterone. And then the bias on the women's side is there for other reasons that are, you know, we know all that. But yeah, it got frustrating. And so, no, you don't get good training on it. And I think most urologists would probably admit that. I mean, I have friends urologists that I think would definitely admit, and a lot of them just don't have a passion for the hormone patient. As you know, like most hormone patients, the relationships you build, that's a big part of it, is you learn intimate things about these people and they rely on you it almost becomes a friendship, partnership, counseling type thing. Not counseling, but you know what I mean? Like there's a rapport that's
Right.
established. When you're mainstream medicine, you don't have time to establish that. And so these urologists now are seeing 50, 60 patients a day because they keep cutting all their insurance reimbursements.
Yeah.
You know, they're so stressed out. Like, you know, it's just crazy. So they don't have time to become experts in hormone optimization. They just don't. I was in a fortunate position where we worked that was a lower volume type place, regional kind of medical center, that I was able to get in testosterone patients and still make it a focus and still be in that insurance model at the time because you're employed. Like, it was just this very unique scenario for me and for us. But anyway, yeah.
Yeah, I mean, even like, I mean, my background is the emergency department and urgent care, and you would give people about 90 seconds with me, and you know, then I'm done. I got to go do my other stuff and figure out what's going on, you know, where labs, whatever. And so I was like, here, I mean, I spend 60 minutes with them, and it's like I'm still the same person. It's just I set up the environment to make it, you know, so that I can talk about how well they sleep or relationship status, you know, or, you know, that kind of stuff.
Exactly.
From a urology standpoint, I mean, one of the controversies we hear a lot is this going to give me prostate cancer, or will it worsen the prostate cancer if I have it? I mean, luckily we have Dr. Morgenthaler's stuff to lean on, but nobody almost knows about it unless you have heard of Dr. Morgenthaler.
And that is the thing we actually did discuss in residency. Thank goodness. I remember one of my co-residents in my upper levels had presented it maybe as part of one of his talks. We had to give talks, you know, different mornings. And, or we at least discussed that. And I thought I started looking into it, and this was probably 2012. Something like that. And so Morgenthaler had started doing it, I don't know, maybe 2009. I can't remember exactly, but so he did a lot of great studies to falsify the claims. The dogma, you know, that everybody had from the 1940s was testosterone will either cause prostate cancer, or if you have it, it will add fuel to it's like throwing gasoline on a fire and it'll explode and kill you. And this was just dogma. People just said it like they do today about all kinds of things without ever actually going, how do you know that? And did anybody actually ever show this? Well, you can ask that about a lot of other things in medicine, but we won't go down that rabbit trail.
Right.
But thank God that Dr. Morgenthaler and his team and the researchers have decided this might be worthwhile to look into. I mean, heaven forbid we actually try to see if something was shown to be true. So they basically first couldn't find any evidence for it. They went back and, you know, he's got good papers on the history of how this dogma started. It's worth reading. But basically they actually started treating people in smaller numbers at first and then larger with prostate cancer, or with a history of prostate cancer, you know, recently treated prostate cancer first. And then, you know, they kind of show over time, no, it doesn't increase the rate of recurrence, you know, versus other people. And then eventually they started doing, well, let's see what happens with people who have prostate cancer but are watching it, like on active surveillance. So like low grade, Gleason 6, 1 or 2 cores, just going to watch it. These men have low T symptoms. They still need help. They want to feel better, right? They want to function. And so they started putting men with prostate cancer in active surveillance. No change in their progression versus others, you know, who are on TRT and have prostate cancer. And in fact, what I saw in practice, because I started doing this, you know, once Morgenthaler had done enough papers and they'd really shown it was pretty obviously falsified. And that took years to really, I think, for them to feel comfortable with that and get the numbers. But it doesn't take much to falsify dogma. But anyway, I started doing it in my own practice, and I saw improvement in PSAs. I saw guys we'd do repeat biopsies. Let's say they'd had one a few years earlier when they were diagnosed, and we'd never find it again. They'd do it again a couple years later, never find it. It was like Okay, was it false diagnosis at first? Yeah, maybe. But some of these were definite multi-core prostate cancer. And then it doesn't mean they got cured from it. It just means nothing worsened. Their PSAs didn't go up. We didn't find any extra new cancer on any weekly biopsies. MRIs looked good. And so they finally started showing that. And so that's been a big help to me. And I think that slowly, even now, still trickling into the urology world. It's very slow. The younger crew coming out, at least when I was getting out of residency, we're learning this. I don't know now what medical education is like anymore in residency programs, so it could go.
Right.
Who knows what the testosterone dogma is going to be like? But so that's another thing to keep in mind. But anyway, it's very interesting to see that all of this dogma, and you'll have people that will still try to fight you on this and put up observational studies with baseline labs to show correlations. It's like that doesn't matter. Like we have interventional studies where you actually give the variable to see if it actually causes the thing you think it does. And guess what? It doesn't. Like that's how this is done. So, but people, those biases die hard. And for some reason they need testosterone to be a bad guy, or then it becomes estrogen, or then it becomes DHT or whatever, cholesterol. I mean, for
Yeah.
whatever lab marker they want to make it the new bad guy, they do.
And even if they've had radical prostatectomy and, are now having, or even before, but no one would do it. Now they've been out, they've got their prostate removed. They still can have TRT, and it doesn't look like it's causing any biochemical reoccurrence or anything like that. Or have you seen anything different?
Nope. That's 100% correct. In fact, I mean, I've had some guys that were on TRT and we sent them out for radical prostatectomies to like Dallas, and they stayed on their TRT while they were getting their surgery. And I mean, to even have a urologist not tell them not to stop it, that's impressive, so that,
Okay,
that's a good thing. But guys, they've done some studies now showing early, maybe regaining continence a little earlier and sexual function better if you start these guys on TRT. It's like, well, no kidding. They should never.
Nice.
They've already been on it the whole time, in my opinion. If we really believe this, if we really believe the research, we should then function like that and live like it. And that's kind of how I do it. I mean, why wouldn't we do this if we know it?
Right. Kind of back to the dogma. I try not to be really dogmatic about anything in medicine. I'm pretty open to a lot of things, but I still I've managed a lot of guys now on testosterone, and I still don't have a single one on any type of aromatase inhibitor or anything. Do you measure estradiol, estrogen? Should we be monitoring estrogen in these guys? You have actually, kind of taught me a lot about this over the years, and so I've looked at your stuff. But I just kind of, for everybody else, what are your thoughts with this and everything?
Yeah, I mean, this is one that I had to learn, because nobody's taught any of this. And if you go with just the traditional allopathic mindset, algorithm based, like if you see a lab value and then it's in the red, we just immediately think that's bad. Okay, so that's one dogma already that's built in. So you have to start peeling back the layers of the onion. And first you start asking, like, does this lab actually mean much? How was it validated, that E2 is actually causing these symptoms? And then you start looking into what they say about aromatization. Aromatization, for people who don't know, is just the conversion of testosterone to estradiol. And estradiol is considered more of a female hormone, right? And so it's been given a bad rap, I think, more in the bodybuilding world. And not sure why, honestly, even that's the way it is, but it just is. And I understand when you're trying to get into a competition and shredded like they do, and they need to eliminate anything that might possibly cause water retention, then they're going to do whatever they have to. But that has nothing to do with people needing to block estradiol when they're taking testosterone. So no, I don't check serum levels anymore because I learned, by looking at the actual aromatization research, not just correlative estradiol research, but little deeper level stuff that when you really start thinking about it, it makes sense that, this estradiol and DHT as well, they're converted in the tissue, at the tissue level. It's not just boom, it's in your bloodstream when you take it, and then poof, it converts in the bloodstream and goes and kills you. It doesn't work like that. It has to actually get into the tissue, at least according to the current thinking on this. And it kind of fits with what we're talking about and what you see in the real world. But basically, that blood level you're getting is really just not meaningful to anything based. You can't correlate it to how somebody's feeling. You can't correlate it to a brain level versus a bone level versus a muscle, whatever the compartment is. And once you understand that, and the fact that when you've constantly blast guys with AIs based on a abnormal estradiol and they get worse, like you start putting all these puzzle pieces together. And Neil Rousier is one of the best at showing the the negatives of aromatase inhibitors. So anybody that hasn't watched this 3 or 4 part series with Jay Campbell needs to watch it. It's from like 6 or 7 years ago, I think, at this point. But you just start putting those pieces together, and I was like, this explains so much. And it was my case, when I took aromatase inhibitor the first few years of TRT, and I never felt like I thought I should. And because I didn't take those in college when I'd taken steroids and taken testosterone, I felt great. And then when I get on TRT and I'm watching certain people on YouTube who say you need to keep estradiol between 20 and 30, picograms, blah, blah, blah.
Correct.
And I'm like, okay, well, I need to do that. These people know more than I do. I'm just in residency at that point, And so, I started taking Aromasin and feel like crap for years and finally stopped taking it. And for myself, I was like, okay, I don't need it, right? But when I got into practice, I threw an AI at a couple guys based on a serum level, and they got worse. And finally, I was like, let's just bump your testosterone up and see what happens. And that's when I started learning about symptom management over lab chasing. So, yeah.
Right. So that's a good kind of transition into, like what are you going to get? What level are you going to get my testosterone to?
Yep.
Where do you guys feel the best or anything? Do you have a specific number that you treat to, or how do you manage that?
I don't, honestly. Again, I have to live by the principles I state that I believe in, which I do believe in symptom management. I don't believe that even the baseline numbers can tell you anything about the person's need for testosterone. In the same way that the size of a prostate can't dictate whether the person is going to have obstructive urinary issues or not. It's not. It's about the actual issue that the person's having. And so because I believe that, I try to base it off how they feel. On a bell curve, I usually can tell you where I do see most guys feel fine. You know what I mean? We can always play the numbers game, and I always tell people you get somebody between 1,000 and 18, or let's say 800 and 1,800. Okay, let's say that, and a free T between 20 and 40 nanograms per deciliter. They're probably going to feel pretty good somewhere in that range. But there are outliers. There's guys that feel great at super low levels that you wouldn't expect, and there's guys that feel great at high levels, and vice versa. It's all over the map. So I don't shoot for a target value other than the one where they feel their best within reason. Like if they're going to chase a number, then I think that's not a valid reason to go up on your dose. If you're not honest with yourself and you're chasing a number but feel worse, like those guys always tell them, like, just be honest with yourself. If you go higher and you start noticing negatives like anxiety, increased blood pressure that you don't like, just all these things that, erectile dysfunction comes back, then go back to the dose where you actually felt good.
Right.
It's that easy.
Yeah. Yeah. And then something that kind of comes up, I'd say pretty frequently, is that they'll just get random lab work, their PCP and everything. And they'll message me and said, hey, my hematocrit was 51. My doctor said go donate blood, so I'm going to go do that. But do we need to do anything from a testosterone standpoint? And, the Endocrine Society says keep it below 54, and so everybody kind of has these random numbers that they say, but at the end of the day, do you feel that the hematocrit is anything in regards to therapeutic phlebotomy or needs to be addressed at all?
I can say I don't know. All I can tell you is there's no evidence that it's harmful. And people will, again, throw correlation studies at you where, of course, people that are sicker will often sometimes have higher hematocrits and all these. It's like, yeah, so what? That has nothing to do with secondary erythrocytosis, which is the elevation in red blood cell count due to taking testosterone. Is that harmful? There's no evidence that it is. Where you have plenty of evidence where there's no evidence of increased clotting risk with TRT, well, they're not controlling, that I can tell in a lot of the studies, for hematocrit. Or, you know what I mean? I don't know how well they're looking at those things, but I can tell you from an anecdotal standpoint or from a clinical experience standpoint that phlebotomies make people worse over time if they're frequent. Now, some guys want to do it 3 or 4 times a year. I think 3 times a year max usually, but 3 or 4 times a year is fine. These guys that are wanting to do it every 6 to 8 weeks because their doctors don't understand that the more they do it, it's just going to keep chasing that dragon more. That's harmful. And so I tell guys that I don't have any evidence to tell you to go do a medical procedure to lower that number arbitrarily. And in my mind, that's the right position to take. I cannot advocate for that with a positive claim that they need to do it. If they want to do it because they're anxious about it, then that's on them, right? That's how this always goes back to the patient. And that's what I think most doctors do not understand because of the model and the way we see people in traditional medicine. They lose sight of this part of this other person sitting there in the room they're the one that's going through something. And so at the end of the day, they kind of have to also take responsibility. So you kind of help them do that. You give them that responsibility play with their dose, tweak these things, but be honest with themselves and yada, yada, yada. And if they're anxious about it, yes, I'll try to tell them the facts that I know, what I can tell all the stuff that we're talking about. But if they're still anxious, they got to do what's right for them. I'm not writing for frequent or for therapeutic phlebotomies for people because I can't justify that. And I know that it actually can cause harm. A massive amount of blood dumping is not a natural thing per se. I mean, other than females over 5 days or whatever, but that
Right.
releasing a large amount of blood at once is not always a physiologically good thing that we know of. But I'm not going to argue that it's bad for you either. Right? That's not my point here. My point is just, it's hard for me to advocate. Same thing with aromatase inhibitor use. I can't advocate for pushing a poison on people because that's what it is technically. I can't advocate that without evidence that I need to, and there just isn't any, and so that's how I feel about the phlebotomy.
Yeah, and I mean, from the crushing estradiol and everything, it's like if you look at a menopausal female, their joints hurt, they're moody, they gain weight, and it's like, I don't want to, one, cause that, but even on the other side, we look at the benefits of estradiol in guys, you feel better. That's where probably a lot of the libido comes from, mood comes from, erections come from. So there's a lot of positive benefits to it. And so I just don't want to crush it on them, to make them a menopausal female at the end of the day,
I mean,
so.
Yeah, and what people don't realize too is that these medicines, these drugs don't work per se the way they're named, right? They go, it just inhibits aromatase and that's all it does. It's like, no, that's not how these work. They're not that selective. We're not that smart, right? They do all kinds of things in the body. Most drugs do. And that's why they call them side effects. So they're not side effects. They're just effects. They're side effects when they're ones we don't want them to have, right?
Right.
They're just all effects of drugs. And so these aromatase inhibitors don't just only suppress aromatase, right? So I think people need to understand that too. And so again, if you want to take something that has known harm for no real proven need, that's on them. I won't prescribe it personally.
Right. Yeah, and a lot of times changing dose, frequency, kind of can help alleviate a lot of the symptoms they feel. Is just kind of estrogen is a scapegoat.
That's
a
right.
lot of times.
That's
like,
right.
Hey,
That's right.
this changed. It's got to be my estrogen, and it's like, well, let's
Pick a number.
try changing this.
Pick a hormone out of the hat. Pick a process that you know about out of the hat. We don't know, and people want a story to insert in there to make themselves feel better about why it happened. It's like, it doesn't matter. All we just need to tweak it and do trial and error until we figure out where you feel best on what protocol and what dose. Like, it is that simple, but it's not simple at all for some reason.
Right. Another thing that I've just kind of seen in clinic is like once I started doing hormones and everything, I really expected my population to be about 45 to 65 mainly. But I'm frequently seeing my even mid 20s to mid 40 or, upper 30 guys with much lower testosterone than my mid 50-year-old guys, And so it's kind of odd that my, population is probably honestly 30 to 40 more than 50 to 60. I mean, I have a few in there, but it was just surprising that I have so many in that age range. What do you think is contributing to this, epidemic of low testosterone in guys?
I would be lying if I even told you that I had an idea, because pick a variable. You know what I mean? Like, there's something going on. There seems to be a decline in sperm counts as well, not just in America. And averages here. We're talking about averages. But that can be significant. And then we start seeing normal ranges change on labs over the years. Okay, this is interesting to me. And so whatever the cause is, I mean, you could literally probably name quite a few things that would probably be true, but are they ever going to be proven in an experimental way? No. But we can speculate about endocrine disruption, with the plastics and glyphosate, all these things, the pesticides. I mean, my wife and I got really into this stuff a few years ago. We started realizing how poisoned we were everywhere. But you can drive yourself crazy. You can drive yourself crazy with that too, because you can't eliminate, unless you, I always tell my patients, like, unless you're moving to self-sustain yourself in the middle of the wilderness somewhere with pure clean water, I mean, everything, then you're kind of at risk of whatever the world's providing, and where you're at. So you do the best you can, eliminate these toxins and things. But I think a good diet as best you can with whole foods, a lot of sunlight, exercise, all the normal stuff, good sleep hygiene, and stress management, and then hormone optimization, and you're going to be pretty set for most things, as far as like obviously unforeseen things happen, all kinds of things happen, but to maximize those things, like you need to be doing.
Right. And some of these guys, like they're young enough to where they really haven't even started building a family yet.
Yep.
But they're, I mean, essentially suffering with low testosterone symptoms. I will say it's probably one of the more complicated ones to manage, because I do, want to think about a decade in the future on like, okay, what if they want to try for a third or fourth kid and they have none today? And we need to get him on testosterone so he stays functional. What do you think what is your approach to managing kind of your younger population
That,
and guys?
it's a hard one, man, and that's one I've dealt with a lot. I think a lot of people, those guys got sent to me as referrals. That's where I built more confidence in this segment, was as a urologist who was willing to take on these guys from far away as referrals, because they legitimately had symptoms. There was something obviously going on, and nobody would touch them. And so it became down to informed consent. We go over everything when they come in, to the risks of possible, fertility issues when you take testosterone. If they're already starting with poor fertility, it's like, I mean, we got a lot more leeway actually to do some stuff to see what you can do,
Right.
but if they're wanting to maintain it, you just give them, the facts that it's possible this will decline because of testosterone. What I recommend is always upfront semen analysis, cryopreserved sperm, just in case you need to use it in that fashion. And then I like to get periodic, at least every 6 months, semen analyses while they're on the testosterone. And also usually tell them to trickle in HCG at least about a couple months after they start their TRT. Once they're dialed in on the testosterone, I do like to trickle in low dose HCG alongside. I mean, I don't know. I can't prove that it actually helps or not in that person per se. But there's studies that, indicate you can do that. It may help. But yeah, it's becoming prominent. I will say I have a classic case of a kid. I call him a kid. He was like 21, newly married. Great guy. He's in Paris, Texas, and he was having issues, and they put him on aromatase inhibitors because he had low T, but they wanted to get his sperm count up too. I think he had a semen analysis as well, and he came to me. They put him on letrozole, which is the most powerful, potent one.
Yeah.
He felt horrible. I mean, newly married, and I was like, we got to do something different. So we got him on testosterone cream, and we got him on HCG without FSH, I think, at first. And I think that for him, the HCG alone was enough to stimulate everything. His count went up. He's now on his second kid with her. He's been on TRT the whole
Nice.
time. So I have quite a few guys in that camp, probably more than most providers, just because I did get comfortable with it during the urology years.
Right. Obviously my phone listens to me throughout the day and everything. I just talk about testosterone and stuff. So I get just tons and tons of ads of Enclomafine basically being, the TRT for these guys. And what are your thoughts, just SERMs in general, urologists will still use them for young guys. Sometimes you can use them, I try to do kickstart protocols if it's a guy
Yep.
off steroids,
Yes.
trying to get his fertility back or anything like
Yes.
that. But anyways, like, do you think Enclomafine is as effective as what, these clinics or pharmacies claim it to be? And do you use it ever?
I don't use it. If I have to use a SERM, I'll use tamoxifen because it works just as well with less nasty effects, in my opinion. And there are other providers who would agree with that. I think. I mean, it's all subjective, but that's what I've seen. But that's really, there's only selective cases. I think a restart protocol, absolutely. I mean, it makes sense to do that then. Every now and then, if somebody gets some early onset really bad nipple sensitivity when they're adjusting their TRT, you can stabilize things with a short course of a SERM, like 4 to 6 weeks. They come off and then they're fine. But as far as like replacing your testosterone, it doesn't work that way. So this is what people, I think, also don't understand. And it's a controversial thing to say, and I don't care. I have reasons for thinking it, but chasing that number on a lab is not the same thing as taking a substance that gives you that same number. It's not the same, because we know that in real life when we give the substance and see what happens versus giving things like Enclomafine, artificially moving a lab number and people feeling horrible. And that's generally what happens on SERMs, is most guys will feel worse. There's a select few that might feel better, but that could be just as easy placebo. But if you'll start searching forums and talking to people, you'll see that when they talk about when they were originally put on things like that, and then what happened once they got on testosterone and the difference. So they play on the fear of infertility, but testosterone is not birth control. There is a risk of lowering a sperm count, but again, you don't know where guys start if you don't get a baseline. A lot of this fear of it suppressing may not be as profound as people claim. You can look into that in studies. It's all been studied, but I'm just saying it's not a guarantee that you're going to have zero sperm just from taking testosterone. There are plenty of guys on TRT group ads.
Yes, exactly. Yeah. The ones that aren't trying to get it are the ones that
Yeah,
end up with the
that's
kids,
right.
and everything.
Yeah.
Um, and yeah, so I always say, it's like they don't typically have an enclomafine deficiency. They
Exactly.
typically have a testosterone
And
deficiency.
again, people don't understand these things cause lots of effects in the body that are unpleasant. It's not just doing what people say on paper that it's doing. Like that's not how these work at all. People don't really know. And if you talk to an actual people in the drug manufacturing, like kind of chemistry industry, a lot of them will tell you like, yeah, we have no clue how these things work. They have databases and they use them on certain things to see what the effects are, and then they eventually make it to the public. So just people need to be careful with what they're putting in their body. And so that's why I'm always like less is more and one variable at a time kind of guy. And also take the minimal amount of things you need to tick the boxes that you need to tick. But in my mind, taking a hormone is a completely different category than taking a poison drug that is short circuiting a natural normal process the body's supposed to be doing.
Right. Yeah. And kind of, I'm not anti controlling cholesterol and everything. That's kind of controversial as well, but I would much rather optimize hormones, optimize lifestyle than move forward with any medication. I still use, antihypertensives and stuff if I need. And sometimes that's how I get. Sometimes I'll lure guys in with testosterone and, it's like they're 55. They haven't seen a doctor or a provider since they're pediatrician.
Yep.
And I'll find they're diabetic, their blood pressure is way out of control. They, pretty much low testosterone accompanies that. But then I'm able to at least address, their out of control diabetes. I mean, I've had guys, and testosterone will help facilitate a lot of times. They'll feel so much better.
Yep.
I mean, I have one guy at a hemoglobin A1C of like 13. He's now down to less than 6.
Nice.
on Manjaro and
Yeah.
testosterone. There's only things that
lose the weight, and it's amazing. But that's the key, really. And I saw, and you're seeing different patient population than I am now. Compared to where we were, and you're seeing, the gamut of everything, and a lot of unhealthy guys that are still being referred for low T, and then you have to talk to them about all the other stuff going on their. I see their medicine list, and I'm like, okay, this is going to be a totally different discussion than a guy who's already trying to be optimized and just needs that extra oomph that you do get from testosterone, mainly here, mentally. That's the big thing. People have this misconception that testosterone is all about just like wanting more sex or wanting to build more muscles. And it's like, no, the majority of guys that come to me want to feel better here. They're losing their motivation, the mental sharpness. They have this brain fog. And I've been there. Like, I know what it feels like, especially on AIs, on aromatase inhibitors. It's horrible. It's just like you're in the tunnel. For me, like switching to cream is what brought me out of it. But a lot of guys, just testosterone in any form is just what they needed to get them back into the game of life, Yeah,
and I guess that's a good transition into the various forms of testosterone replacement. I mean, there's injections, creams, pellets, troche, even
nasal
Kaiser nasal. Yeah. What forms do you utilize? What do you think is optimal?
Injections or cream. I'm probably 50-50 right now with my patients. I may be more cream now than I was in the past.
Nice.
Yeah, I'm biased personally to the cream because for me it's better, but I'm totally open with my patients that I want them to find what works best for them. If they're new to testosterone replacement, I will often suggest cream first because it just makes sense not to have to burden yourself with anxiety of needles and all this extra stuff. And more variables, right? You have carrier oils in there. You have preservatives. Like, you're adding more variables than just with a cream, in my mind, because you're injecting it, right? You're passing some of those barriers. And so people can have sometimes a harder transition time with injections, in my opinion. From what I've seen, it seems to be easier and quicker to get guys dialed in on cream because it is in your system quicker too. Guys are feeling it sooner. And a lot of these negatives that come on when you start TRT will flush themselves out sooner on cream than injection. So they're not dealing with water retention for 3 months. It's only 4 weeks, some stuff like that. So, but cream or injections are my main two. I think one guy wanted to try like a compounded version of the Natesto, the nasal gel, but you had to use so much 3 times a day. It just, and your level
3 times a day.
Yeah, it's just. I think now they're come out with affordable versions of like Kazatrex or one of the oral undecanoates, but you have to take like 2 capsules twice a day. Like a lot of people are not going to end up, and that's just to get levels up to like maybe 800, and the cost for that's gonna
Yeah.
be like $150 a month. It's like, and that's cash pay, compounded, or not compounded, but whatever, cash pay probably or discounted through the company. It's just not worth it when you can. I mean, I pay, I don't know, probably $40 a month for my cream, and you average it out. It's just, and pellets, are so expensive, and there's such a profit center. And I get it. I get it. Like, I'm not dogging people for making money. I just think pellets, there's a small window of place, place and time when you need to do pellets. And it not across the board. Some people do them and love them and feel great. And I'm like, that's fine. Like, there's nothing wrong with that. But it's okay to, like, a lot of these providers will not do anything but pellets, and they'll lie to people and tell them only pellets are bioidentical. That's where I have a problem with it. Like, don't lie to people. Just say this is
Right.
one option out of many. Like, that's it.
Yeah, I don't know for pellets. I just kind of I think there's too many variables with them, and I that's all I use as well as cream and injections. Just for I can adjust on the fly if
Yeah.
anything's going wrong. Management's pretty good on them. Um, and so I have a lot of guys do really well on like a daily tadalafil, just kind of in terms of erections. If they're not getting the full kind of benefits of testosterone, they do pretty well with that. I have a handful that just after the daily tadalafil, they're just asking what, like, hey, that worked for a bit, but now I'm not getting what I was. Do you have any other erection tips or anything to help the guys that kind of aren't maintaining well with the daily tadalafil?
That's a hard one, honestly, because if they're seemingly healthy, like based on what you know of them, and that's just masking things or helping for a bit, you kind of sort of have to be willing to talk to them about their personal life, like how's their sex life, honestly, like what's their relationship like, are they overstressing, are they psyching, and honestly, you'll often find we men psych ourselves out, right, when we put pressure to perform or whatever it is, your mind wanders. I mean, it happens, and things don't work, and then you can think yourself into a cycle of ED just by that happening. And that's where a lot of times the Cialis, yeah, it'll at first it'll band-aid it, it seems, but then these other issues are still there. Um, if it's a guy who's got really just bad metabolic health, that has to be addressed separate. I mean, yes, you can keep band-aiding the ED. You can go up in your doses. You can combo sildenafil with tadalafil in various ways. You can move on to intracavernosal injections, which we did a lot of as urologists. I don't do it now because I don't want that liability if they get priapism. But it works great. I mean, it really does for almost all guys. Not everybody, but for most men, it really works well. A lot of my really bad diabetics had to get Promase, and then obviously guys after having their prostate removed that had nerves severed, and the Trimix would work really well for them because a lot of those guys don't have arterial disease. They're not bad diabetics, so you go straight to the source and healthy tissue, and so a little goes a long way. So those guys would have to usually need a lot lower dose, which was interesting. I mean, you can keep band-aiding, and then you go to penile prosthesis or all these other things, but it's like people got to be willing to get their health in check, and it's not always that easy. Sometimes the damage is done if they've got severe Peyronie's disease or if they've had multiple priapisms taken down in the past, have scar tissue. I mean, if they've had a trauma to their pelvis, I mean, that's different. That's a different discussion. But as far as optimizing erectile health, it's the same thing I tell guys when they ask me about prostate health. Like, prostate health is total body health. Erectile health is total body health. Just be as healthy as you can, and that's the best we can do. I mean, you can supplement all the things you want, but if all those other things aren't also in place, then the supplement. It's the same with testosterone. If you see a guy that's very overweight with a BMI of 60 and his A1C is 13, and he's not willing to do anything, and he's got a testosterone of 95, putting him on TRT may make him feel terrible. It might protect some bones, and it may improve a little cardiovascular, unseen stuff. We don't know. Is he going to get really much benefit out of it? No, he's not, because he's not putting the work in. And so that's what I always tell people is, like, if you're already willing to put in the work, then it's sort of testosterone will kind of amplify a lot of those efforts and make them go a little further. It's kind of how I think about it, at least.
Right, right. Aside from just the testosterone, getting that dialed in, do you do any other adjuncts with your guys' thyroid,
Yeah.
DHEA, pregnenolone,
Yep.
or like any of the growth hormone secretagogues or anything like
Yeah,
that?
the growth hormone releasers, I've played around with some of those. They took a lot of it off the market last year, and I know some are kind of coming
Hmm.
back now, but I dabbled personally with ipamorelin and CTC 1295. My sleep was fantastic. I think my skin got
It's
better.
awesome.
Yeah, I mean, I liked it.
Yeah.
I would do it again if it becomes actually I could get it gray market. I'm just lazy, but I did like that, and I've had patients take it. Sermorelin, Samarelin or Tesamorelin, however you want to say it. I think it's too expensive for the results that you're not getting. You could just get with ipamorelin. Personally, I know there's other
Mhm.
visceral fat loss. It's like, come on, I don't know. That's anytime those claims come out that much, I'm a little skeptical. So I'd have to see that. But
Right.
thyroid, yes, I did start doing some thyroid stuff while we were still working as urologists. Starting to learn that. We did some of the World Link courses on that just to get refresher. But in the end, it really does come down to trial and error on that too. You just have to kind of understand how these different drugs, even different types of thyroid, will affect certain things, and know what to expect when you do something with the thyroid. What to expect on a lab value, so you don't freak out. I think a lot of confusion I see in like the female groups, especially where they're trying to like game the system for their lab so it doesn't freak out their provider. And it's like you've got a good provider, they'll be able to extrapolate what your labs mean based on how you're taking it and how you feel.
Yeah. And if you feel good,
Yeah, it's
let me know where you feel good at,
yeah, and but that blows the mind of like again I don't want to say that I'm not pigeonholing like individuals here, but the allopathic mindset as if it's like this Borg collective entity that can think. But you know what I mean when I say that. Like it's sort of the what's drilled into you through your training, that algorithm based mindset basically, and this lab based mentality that misses the mark so much that this is a person, they're not a lab number, and it's crazy.
Yeah, and just following that. So I think like I randomly just checked up to date the other day just to see what it even had for testosterone, and I still think it has. I mean, 1 cc every 2 weeks, and then if the hematocrit, I don't remember its number, but then you have them stop testosterone
Yeah, you stop.
completely. It's like, oh my gosh, it's just a roller coaster of hormones.
Yep.
It's like
And that's the problem.
surely somebody's looking into that.
No, I mean that's the thing. People are. It just doesn't make it into the guidelines, and therefore up to whatever up to date's using to get their data to collate and put in there, it's not staying up to date with actual, I would say, true evidence based research. That's the irony of all this is they act like they're evidence based with all this crap, and most of the guidelines are not they're not real evidence. It's usually just statistical correlated nonsense, not interventional trials at all. It's just, I mean, it's weird. Or if they have the interventional trials, they'll still blend them with the others and be like, yeah, it shows that this doesn't happen, but we're still not sure if it happens or not. You're like, it confuses the heck out of doctors. So they're going to err on the side of caution and kind of do what the guidelines say. I think that's another thing is just fear of the liability. But I'm like, in the end of the day, again, show me the actual evidence that what you're claiming is true.
Yeah.
Don't give me a bunch of statistics. Like, I mean, that in a court of law, that's what I think should happen. So I just have to think of it like that. At the end of the day, do the right thing for your patient. Treat the patient as a person. Ask them how they're feeling. Like all that matters. I think you can sleep better at night than just treating them like a nut.
Yeah. Do you use DHEA or pregnenolone at all with your population?
Very rarely. I've had like maybe 3 or 4 guys total on pregnenolone that have benefited from it. I've had many try it, including myself, but the ones who that was what they needed to like tick one more box, it was really just 3 or 4 guys. Dave Lee is big on if they have like basically undetectable levels that it may be worthwhile trial of pregnenolone, and I think that's a reasonable metric to use. Same thing for DHEA. I'm not a big DHEA fan. I have seen it cause way more negatives than positives in almost every person that takes it. I'm still amazed how many women are taking it when I don't feel like they need to be. I I disagree with a lot of the DHEA research because I think it's poorly done. I feel like there's a lot of petri dish studies and things like that, and a lot of again correlative stuff. But again, at the end of the day, if a person takes it and it ticks the boxes they wanted and they feel better on it, and they're not seeing negatives, as far as their body, your body will tell you, things are going to come
Yeah.
off. I'm fine with it, So I do encourage patients because those are over the counter here in the U.S. Unlike Canada, you need a prescription. So here, people can kind of experiment with that on their own, which I like. I'll kind of give them some help finding maybe a source like for good micronized versions of these things. Like there's a few companies that are
Right.
better, I think. But other than that, it's at the end of the day, I'm like, try it. If you feel worse, it's okay to stop it. Don't think you have to take it because you saw somebody on YouTube saying you had to.
I'll use DHEA occasionally for like guys complaining of anorgasmia
Yes.
or HCG. And sometimes I'll throw a P5P in there, but really kind of in the same way. I like it. These are what it could potentially help with. If you want to trial it, great. If you don't feel much, don't push it.
Yeah.
Just you can trial and error if you want.
Trial and error. I mean, and that's what I think
Um,
about a lot of these things, honestly, at the end of the day. Even melatonin, I think about the same way. It's not about chasing
yeah.
a dose. It's what are you trying to get out of it? And if you feel worse, don't take it, you know?
Yeah. Do you have many guys? I occasionally will get the anorgasmia question once they get into testosterone at some point. Do you have many
Not a
complain of
lot.
that?
Only guys I've ever had truly with that were already on an SSRI or something like that. And so that is the issue usually that needs to be focused on. Some of these other meds, like if you look at ADD meds, sometimes can just do weird things. Also, you have to differentiate if it's truly anorgasmia or if they're not even like, are they just shooting blanks? Or are they taking tamsulosin or something like having retrograde ejaculation, like all that stuff.
Right.
A lot of guys though do for some reason, lose penile sensitivity. And so that becomes a big complaint. And that's where I've seen DHE help in maybe like one or two cases, and pregnenolone helped. I know one guy in particular, it helped. Just kind of like ACG can help with that as well. Sometimes I feel like it's speculated chronic tadalafil use can maybe cause some penile insensitivity, but there's plenty of guys that don't get that on it too. So I feel like that's more of a toss-up.
Well, cool. I've been chatting for a while. I mean, I think that's great. I think we covered a lot of topics.
Yeah,
I
absolutely.
appreciate your help. Are you still taking new patients? How can people find you if
Not
they want?
it's more right now kind of referral based. We got overloaded, honestly. Like it was a blessing. Like we got kind of blown up.
Great.
It
Yeah.
was great, and it's still taking a while to get used to that. I'm still trying to find and finally level and get in kind of a cruise control mode. So it's really kind of referral only right now, just because like I said, it's me handling the men, and then the wife, Leah, she's still handling the females, and she is taking new patients too, but same kind of thing where it's more referral based right now.
Okay. Well, awesome. Well, I appreciate your time
Yeah,
for
man.
this. I mean, this was awesome.
Before you doing all this is awesome.
Yeah. Thanks. All right.